Welcome to another surgical discussion video. Here we shall be discussing hemostasis, surgical bleeding, and blood transfusion. If you have ever been stared at by a cow, you will realize and agree with me that they give you a very philosophical look. The cows will just stare at you and cast a very vague look on you. This is the mnemonic that I use to remember the entire coagulation process. BFEF, that is like beef, has a very vague, it casts a very vague look on you. The hemostasis takes place through three steps, which you are all aware of: vasoconstriction, platelet aggregation, and coagulation cascade activation. But once the fibrin clot is formed, you can't keep on having the progression of the fibrin clot. Therefore, there is also fibrinolysis to maintain the patency of the blood vessels. The initial response of vasoconstriction occurs because of the production of thromboxane at the site of injury. But this vasoconstriction is sustained during the platelet aggregation phase by endothelin and 5-HT, and also sustained during the coagulation phase by bradykinin and fibrinopeptides. Platelets are responsible to form a hemostatic plug, and they contribute to thrombin production. Platelets are anucleate fragments of megakaryocytes, and usually they are between 1.5 to 400,000 platelets per cu blood. They have an average lifespan of a week, and normally they don't adhere to each other or the endothelium. They do so only when the subendothelium is exposed. Now this brings us to vague. The von Willebrand factor binds to the subendothelium and also the glycoproteins on the platelet membrane. This initiates a release reaction which recruits other platelets to block the rent, forming a platelet plug. This is a reversible reaction. The platelet aggregation is mediated by the mnemonic, ASA, by ADP, serotonin, and arachidonic acid products. Now here there is going to be a strange dichotomy. The arachidonic acid products, thromboxane, causes vasoconstriction and platelet aggregation, whereas prostacyclins causes vasodilatation and it inhibits the aggregation of platelets. So both of these are diametrically opposite, thus showing you that not necessarily there is only a plug formation, there is also an inhibition so that the plug formation doesn't take place in the entire vascular tree. This step is inhibited by the NSAIDs because they inhibit the COX and the LOX pathway. The second wave of platelet aggregation occurs when there is a release of calcium, ADP, serotonin, thromboxane, and alpha-granule products or alpha-granule proteins. Fibrinogen is very essential for this process because it acts as a bridge between the platelets. This process is not reversible. Thrombospondin, as the name suggests, stabilizes the fibrinogen to the platelet surface, which then increases the platelet-to-platelet interaction. The second wave of platelet aggregation can be inhibited by NSAIDs and aspirin. After this release reaction takes place, that is the second wave, there is an alteration in the phospholipid membrane, which allows calcium and clotting factors to bind to the platelet surface, which forms an enzymatically active process. This activates factor 2 in the presence of calcium, factor 5 activated 10A and 7. Thus, this tells you that once the second wave of aggregation takes place, the platelet starts activating the clotting factors, and the intrinsic and extrinsic system get activated because platelets can also play a role in the initial activation of factor 12 and factor 11. The coagulation pathway can look pretty daunting. It's simple to remember that the extrinsic pathway is started by factor 7 and the intrinsic pathway has factor 12, 11, 9 and 8. Both these pathways move on to the common pathway where factor 10 gets activated, which then activates factor 5, factor 2 and lastly factor 1. Once the coagulation cascade is started, it doesn't mean to say that the whole vascular tree gets a thrombus. This coagulation pathway is also being inhibited by thrombomodulin, which binds with thrombin and then activates protein C and protein S, which then inactivates factor 5 and factor 8. The coagulation cascade, as we have seen, doesn't keep progressing unbridled. It's also inhibited by the thrombomodulin. Once the fibrin clot is created by attaching with platelets and a thrombus is created, the tissue plasminogen activator gets active, cleaving plasminogen to form plasmin, which initiates fibrinolysis. And fibrinolysis will then maintain the patency of the blood vessel. A way to remember the extrinsic and intrinsic pathway and warfarin etc. is this: that the professional soldiers, prothrombin, go to war, warfarin, and they usually go outside the country, extrinsic. And if you want to be stylish or you want to be hip, you can do so only partially inside your country. Obviously, because you feel shy, your relatives are seeing you. Therefore, partial thromboplastin time checks the intrinsic pathway inside, and it's usually the heparin which acts on this pathway. And now that hemostasis is clear, let's move on to the congenital and the acquired factor deficiencies. One thing to be kept in mind in all these deficiencies, whether congenital or acquired, is that the treatment is usually replacement by factors, cryoprecipitate, FFP and platelets, because in the end one would want to create a stable fibrin plug. The three most frequent factor deficiencies congenitally seen are factor 8 deficiency, hemophilia A, factor 9 deficiency, hemophilia B or Christmas disease, and hemophilia C, which is factor 11 deficiency. All of these are X-linked recessive, meaning to say that the males have an X and Y chromosome, whereas the females have an X and X. So thus, when there is an X chromosome which gets affected, the females have another dominant X, so they don't have any clinical signs, whereas the males are affected clinically. Now, the severity of the disease depends upon the measurable levels of factor in the patient's plasma. If there is less than 1% of measurable factor, it's a severe disease. Up to 5%, it's a moderately severe disease. If there is 5 to 30% of measurable factor, it's a mild disease. These patients usually have intra-articular bleeding, retroperitoneal hemorrhage, rectusheath hematomas, and they could have bleeding after major trauma or surgery. The usual treatment is to replace with factor 8, factor 9 concentrates depending on the disease, and at the same time one can even give recombinant factor 8, which is given for patients who have not been treated previously, and also those who are HIV and HCV seronegative. When replacing these factors, one should see the activity levels being restored up to 30 to 40% for mild hemorrhage, 50% for severe bleeding, and up to 80 to 100% for life-threatening bleeding. 1 out of every 5 patients with factor 8 deficiency develop inhibitors to factor 8. In these conditions, one would need a higher level of factor 8 for treatment. People have also tried porcine factor 8, prothrombin complex concentrates, and activated prothrombin complex concentrates in the hope to form a fibrin stable clot. A stable fibrin clot, Factor XI deficiency or hemophilia C is very interesting. This is because those with factor XI deficiency are protected from thrombosis, and at the same time they have a minimal risk of bleeding. So this almost parallels a patient who is getting anticoagulation, where there is minimal risk of bleeding, at the same time they are protected from thrombosis. Patients who have VWF factor disease either have a quantitative reduction in these VWF, or there is a qualitative defect in VWF, or a total deficiency of VWF, type 3 disease. The treatment for this is VWF concentrates. Very rarely, patients may present with a deficiency of factors 2, 5, 10, 7 and 13. These are very rare disorders, and they finally present with a bleeding diathesis. So when one wants to cause bleeding and a stable fibrin clot, the treatment for most of these conditions is using fresh frozen plasma. If one does know that there is a certain factor deficiency, then the certain factor, for example factor 7A or factor 13, may be used for the treatment of this particular problem. Platelet defects could also cause troubles in the platelet plug formation, either because of an abnormality in the platelet surface glycoprotein, or abnormality in the granules, or even their enzymes. The treatment for this condition is a platelet transfusion. Acquired hemostatic defects are also treated by replacement of factors FFP, cryoprecipitate and platelets. But here one should understand the mechanism, so it will help in the treatment of your patient. Platelet abnormalities could either be quantitative or qualitative. Quantitative defects occur when there is a lack of production because of troubles with the bone marrow, myeloproliferative diseases, deficiencies of folate and vitamin B12, chemotherapy or radiotherapy, decreased survival of platelets because of DIC, ITP, TTP, or increased sequestration of platelets because of splenomegaly, portal hypertension, lymphoma. The qualitative disorders of platelets could occur because of massive transfusion, where there is a mismatch between the blood volume and the platelet concentrate, again because of use of aspirin, clopidogrel, and certain disease states such as acute liver failure. The treatment for these conditions is finally platelet transfusion. Hypofibrinogenemia could occur as a primary condition, most of the time occurring after a prostate surgery, where there is release of urokinase. Thus the fibrin is not stable, and the treatment for this condition is either epsilon aminocaproic acid or TXA, that is tranexamic acid. DIC is an acquired syndrome usually seen in sepsis, MODS, snakebite, certain kinds of drugs, and pancreatitis. There is a systemic activation of coagulation pathways, which finally results in excessive thrombin generation and a diffuse formation of microthrombi all over the capillaries. Ultimately, there is a consumption and depletion of platelets and coagulation factors, and this deficiency finally results in diffuse bleeding. Also, in addition to this, there is a microvascular ischemia which is caused because of the coagulation inside the capillaries. The diagnosis of this condition is usually based upon the etiology of the disease, the various conditions which we just discussed. There is also associated thrombocytopenia because the platelets have been consumed. The prothrombin time is prolonged, which shows that there is a failure now of the extrinsic pathway. There is a low fibrinogen level, pointing to the fact that fibrinogen has been used. and there are elevated fibrin markers. The fibrin monomer joins to form a dimer. So these D-dimers increase because of the excessive fibrinolysis that occurs. The treatment is usually directed at treating the cause, such as the pancreatitis or the sepsis and the MODS or the liver failure, in addition to which one should use FFP, cryoprecipitates, fibrinogen concentrates and platelet concentrates, along with which one should also start heparin therapy. Myeloproliferative disorders such as polycythemia can lead to spontaneous thrombosis because of the thickening of blood due to the excessive RBCs. The treatment here is low-dose aspirin to basically inactivate the platelets. The liver disease can also lead to coagulopathy because the liver is the site of production of all the coagulation factors and also certain anticoagulant factors. So these levels reduce with liver disease, and there is an imbalance between the pro and the anticoagulant pathways. Conventional coagulation tests are not useful to interpret the extent of disease. Therefore, TEG is more informative in this condition. The coagulopathy of trauma is equally fascinating. The traditional teaching is that the acidosis, hypothermia, and dilution of coagulation factors result in coagulopathy. Whereas it has been shown that almost 1/3 of injured patients have coagulopathy at the time of admission. And this significantly increases the risk of mortality, especially in the first 24 hours. The mechanism to explain the coagulopathy of trauma are two factors. First of all, the shock, and second of all, the tissue injury. Tissue injury, as you know, can activate the extrinsic pathway, and therefore it can start the coagulation process. But when there is shock, this induces a coagulopathy because there is an activation of the anticoagulant and, in addition to that, fibrinolytic pathway. When there is hypoperfusion, there is activation of the thrombomodulin, which then activates protein C and protein S, which then deactivates factors 5 and 8. Therefore, now the coagulation cascade has been inhibited. Furthermore, there is activation of the fibrinolytic pathway. Therefore, if ever there is a clot, the clot is getting lysed earlier. On the other hand, the tissue injury causes coagulation. Therefore, when there is a blend of these two, the patient finally ends up having the coagulopathy of trauma. Please refer to the video on venous thromboembolism to get a better idea about the anticoagulation and the drugs that are used. Spontaneous bleeding can be a complication of the use of these therapies. And when that happens, the drug effect should be determined with an assay of the factor 10A activity. Warfarin is also used very commonly, and it is associated with a significant increase in morbidity and mortality in acutely injured patients. Warfarin can be reversed by administering vitamin K, cryoprecipitate, and at times even recombinant factors. The newer anticoagulants such as rivaroxaban and dabigatran have no clear-cut methods to detect their activity. At the same time, there is an absence of reversal agents. Dialysis is used for dabigatran, whereas factors 2, 7, 9 and 10 are used for rivaroxaban. Once there is a use of anticoagulant, and if heparin has been used and the APTT is less than 1.3 times control, and if warfarin is used and the INR is less than 1.5 times control, the reversal of anticoagulation is not nearly really necessary because there is no risk of bleeding, and at the same time there is a reduced risk of thrombosis. Thanks for watching. Like, comment, subscribe, email me.